Um, Thank you, Sridhar. And um, essentially, neonatal intensive care, particularly of preterm babies, has got preventive care as a major component. Most of our work actually involves supporting these really mature organs, sometimes forcing them to do their job through mechanical ventilation or whatever. So one of the price that we pay is causing the damage. So the preventive work involves how do we limit that damage? How do we screen for those damages? So in the next a few minutes, I'll talk about two important consequences which can really have a devastating consequences, and they are ROP and intraventricular hemorrhage. Now, why do we care? Intraventricular hemorrhage has been described as an incidence is about 25-30% in very low birth weight babies. But more importantly, especially when babies have severe IVH, more than 50% of them can have such serious cognitive problems, such as or cerebral palsy or even hydrocephalus. But what's even more worrying is even those babies who do not have these organic problems, such as the CP or the hydrocephalus, they are at risk of psychiatric disorders or problems with executive function, ability to process complex information, etc. So the IVH does have those devastating consequences in preterm babies. Whereas ROP, if you just look at 2010 data globally, the estimation was there were about 20,000 babies who were blind or severely visually impaired, and another 12,000 who had mild to moderate impairment. And some commentators write that currently, especially in the newly industrialized countries such as the India, Russia, Brazil, China, because of the increased survival, we might be looking at the third epidemic of this ROP. The first two being the first one in 1940s when it was linked to oxygen, the second one in the 70s and 80s when it was linked to the increased survival of babies who were born very low birth weight. So both these have really serious consequences for the preterm babies. Now, if you look at IVH, nearly 50% of them develop by the first 24 hours, and most of them would have developed by 7 days of life. And of those who develop IVH, a third of them, up to 40%, may have progression of hemorrhage over the next 3 to 5 days. So essentially, the problem with the IVH, especially the acute problem with the IVH, would have occurred within the first 2 weeks of life. So this really focuses us, to if we have to take any preventive measures, it has to start very early on. Whereas ROP, the actual pathology begins between 32 to 34 weeks of corrected gestational age and advances till 45 weeks gestation. However, the foundation for this development of ROP begins very early on. So again, the focus for us has to start very early on. Now, I'll talk very briefly about the pathogenesis of both the conditions. The reason being, if we start focusing on the pathogenesis, we might find what preventive aspects we should look at. If you look at IVH, it's quite complex and multifactorial. However, three things stand out. One is the fragility of the germinal matrix vasculature. So the germinal matrix, what we see in the chordothalamic notch and the cranial ultrasound scan, that area, it's an area of high angiogenesis, highly immature vasculature with with a problem with the basal lamina. Pericytes are being less in that area, so it's almost like a dam with a very weak wall. In addition to that, you have fluctuation in the cerebral blood flow velocity. So you can have two sets of preterm babies, one where the peak systolic blood pressure and the trough diastolic pressure remain constant throughout, or you may have another set of preterm babies where the peak and the trough of systolic and diastolic pressure keep varying intermittently. And it is the second group of babies who are really vulnerable for IVH. And thirdly, even if you have that in the change in the blood pressure, systolic and diastolic, if you are looking at a term baby or a child or an adult, the cerebral blood flow is auto-regulated, whereas in an extreme preterm, it's a pressure passive circulation. So the changes in the blood pressure does get transmitted into the cerebrum. So if I have to use an analogy, it's just like a dam with very weak walls and lots of waves which are literally hitting the wall. That's how I look at the risk of IVH. In ROP, it goes through two phases. The first phase is the vaso-obliterative phase. If you think about it, retina develops in a very low PO2 condition in utero. So as soon as the baby is born, there is an increase in the PO2 concentration. So that hyperoxia leads to downregulation of vascular endothelial growth factor and IGF-1, which leads to reduction or avascular state of the retina, reduction in the blood vessels. And this continues till 32, 34-week corrected gestational age, when the more mature retina starts to become metabolically active, and there is an upregulation of the same growth factors, which lead to, again, proliferation of the blood vessels. The only problem this time is that proliferation starts to take place in a haphazard way, not in a structured way. And that's what leads to ROP. And if you look at it, most of the treatment, whether it's a laser or Avastin or whatever, are directed towards phase 2. So the preventive measure that we need to have is, again, very early on, where if we can reduce the problems that occur early on in the vaso-obliterative phase. So that's where the preventive measures come in. So what can we do? So I suspect with all three of us, Deepu, myself, and Dr. Monica, when she's speaking next, there will be a bit of an overlap, because all the evidence that all the preventive measures that we do, they impact one or the other. So first of all, if the longer the baby stays inside the uterus, the better it is. There is absolutely no doubt. If we can prevent a preterm birth, I'm sure the obstetricians will be working really hard on that. And screening for infections, UTI, etc., or giving the prenatal antibiotics if there's a prolonged rupture of membranes, because that is an independent risk factor for IVH, or the use of tocolytics. These are some of the measures that the obstetricians will be looking at. And again, if there is a possible preterm delivery, then antenatal steroids are so important. In neonatology, if I can look at one very important advance in neonatology in the last few decades, it is antenatal steroids, because it has made such a big difference to the outcome of babies. And it's amazing when you look at the history of it. The first research of antenatal steroids came in early 70s, but by the time it actually came into practice, it took another 20 years. If you look at the evidence, IVH, there's a 45% reduction in IVH in babies, in mothers who receive antenatal steroids, especially 48 hours before delivery. And even with ROP, because it improves the pulmonary maturity, again, that reduces the need for excessive oxygen or respiratory support, etc. So again, indirectly, it benefits ROP as well. If you look at magnesium sulfate, which is coming, it's coming in a big way in the last few years. In fact, some of the places, it's an audit, it's a KPI, it's an audit standard, National Neonatal Audit Program in UK that includes magnesium sulfate. Although it doesn't impact IVH directly, but it offers neuroprotection in the form of reduction in CP. And those mothers who are, who are threatening to deliver prematurely, there are sometimes when they attend maternity hospitals where the neonatal setup may not be set up for providing tertiary neonatal care. In those situations, they are better off transferred in utero rather than ex utero, because if you look at this data, where from US, 67,000 infants were included in this study, and as you can see, the IVH and the severe IVH were very less in those who were in the inborn group rather than those who were transferred ex utero. So it's something to consider, especially if in places where there is no facility for tertiary neonatal care. And then delivery, there's no difference in the cesarean section versus vaginal delivery, especially for both IVH and the ROP. There's a small systematic review which is identified that actively resuscitated breech singleton below 28 weeks, cesarean section was beneficial, but these were observational studies. So it's difficult to use this to change our practice at this moment in time. Resuscitation at birth, again, oxygen management at birth is so important because as we've highlighted, the hyperoxia is one of the big problems for ROP. So the use of air, especially for term and late preterms, or if you're trying to resuscitate a extreme preterm, then using oxygen up to 30%, and then adjusting the oxygen concentration by 10% every 30 seconds according to the target saturation that is mentioned in the chart in NRP or NLS, and that's really useful. And maintaining good temperature. All the resuscitation guidelines always talk about how to dry the baby, get it to the wet towel, and cover the baby in a warm towel. And that's so important because hypothermia is linked to increased risk of IVH. Resuscitation at birth, again, continuing with that theme, severe IVH is associated with the increased number of intubation attempts. In other words, if the baby requires serious resuscitation, then that does increase the risk of IVH, and it could be linked to various factors. One of them is intubation attempts and inadvertent delivery of high tidal volumes. So when you're trying to set the pressures in the resuscitator, it's important to look at carefully how much pressure we are setting. And also in the middle of all that resuscitation, it's so easy for us to continue to give long I times or do frequently in giving at a very high rate. So that all can lead to large fluctuations in end-tidal carbon dioxide, and that could increase the risk of severe IVH. These are the things that we need to keep in mind. This is another piece of research where babies who were delivered between midnight and 7 p.m. They had an increased risk of IVH. I think that's more to do with possibly the lack of availability of trained people at nighttime at the right time, possibly. I won't go into the details of delayed cord clamping because Deepu described it beautifully on this. Just to say that delayed cord clamping is recommended, but not cord milking because it does increase the risk of IVH. Now, what are the postnatal measures we can take? And if, as we looked at the pathogenesis, one of the important pathogenesis for IVH is fluctuation in cerebral blood flow. So minimizing suctioning and handling, especially in the first 48 to 72 hours, you don't need to do frequent suctioning. You would have given surfactant, you don't want to do suctioning, and you don't have a lot of secretions in the first 48 to 72 hours. So limiting the suctioning and minimizing the handling, especially after the first golden hour, try and settle the baby and not to handle unless, and you can group your handling with the cares or when you're doing the gases, etc. All of them can be grouped together so that babies have extended periods of no handling, and that is really beneficial. This is theoretically, it has been described where rapid infusion of sodium bicarbonate can change the osmolarity and also increase the carbon dioxide level in the blood, leading to vasodilatation. So it's always helpful to avoid rapid infusion of sodium bicarbonate. Avoid extremes of carbon dioxide because, as we said, high carbon dioxide levels can cause vasodilatation. So that's another area to look at. Again, volume targeted ventilation, not to allow to reduce the risk of barotrauma or volutrauma. And again, there is evidence to suggest that use of volume targeted ventilation does reduce the risk of IVH. I won't go into the details of RDS because that's a separate talk in itself, but managing RDS appropriately means that you are taking control of oxygenation and carbon dioxide, etc. So that's really helpful. And similarly, PDA management, I won't go into a lot of detail here, but there is so much of controversy about the management of PDA, and at this moment, I am certainly waiting for the baby Oscar trial results to be out, so that we might get some idea of how to manage a hemodynamically significant PDA within the first 72 hours. And then, how do we manage babies with pneumothorax? Can have a high cerebral venous pressure, which can cause problems. So make sure that we give gentle ventilation and prevent pneumothorax. Abnormal blood pressure, appropriate fluid management. It's very well known that in the first 72 hours, excess fluid is linked with high mortality, and there is a, and because there can be quite serious fluid management issues in the first 72 hours. So making sure that we weigh the baby every day, making sure that the fluid balance is charted properly, make sure that we address that. Manage hypotension. That in itself is a big topic to discuss. But just if I have to summarize in one sentence, the current recommendation is not just to target a number, but also to look at if there is any evidence of hypoperfusion in the form of raising lactate, metabolic acidosis, decreased urine output, or capillary refill time being prolonged, etc. And managing sepsis again is important in preventing IVH. This is keeping the head in midline has been considered in this, and the reason for this is if you turn the head to one side, one of the concern is that it could cause jugular venous compression, elevation of high cerebral venous pressure, etc. Although the evidence, the studies have not shown a lot of benefit, but it seems logical and it's easier to do. So especially early on, it's something that one can consider. And again, minimizing pain and stress will again lead to fluctuation in the cerebral blood flow. So it's very important to make sure that we handle carefully, we minimize pain and stress. Coagulation disturbance, its association has been shown in studies between coagulation disturbance and IVH, whereas the causal role is not clear because treating these babies with fresh frozen plasma or cryoprecipitate has not resulted in a reduction in the incidence of IVH, but it can modify the severity, I suppose. Retinopathy of prematurity. Now, the most important thing is to look at oxygen as medicine, just like any other medicine. So every increase in the percentage of oxygen, we must be careful. We must think about, is it really required? And we should come down just exactly how we do with any other medicine. And because avoiding hyperoxia is such an important thing in preventing in decreasing the risk of ROP. And it's about wild fluctuation in the oxygen levels that affect the ROP development as well as progression. And I've already highlighted the importance of good oxygen management at birth. Now, what do we do after birth for in terms of management of oxygen? First of all, to set the oxygen target for preterm babies. This again, how much oxygen to give, again, is a good lecture in itself. But generally, the current recommendation is to use an oxygen target of 90 to 95, and we tend to use slightly tighter between 91 to 94. Now, the three charts that I have here are, before I came to Dubai in my previous hospital, I looked at babies who had ROP requiring treatment in the region. I just tried to look at the data, and these are some of the babies who had the saturations recorded on their medical records. And as you can see, the red line is the saturation target. And if you can see the number of times these babies' saturations exceeded the 95% target. So it just goes to show that how difficult it is to control keep the saturation targets within that limit. However, we really need to make that effort to reduce that. And how do we do that? We need to set an appropriate limit on the monitor. When you're doing the ward rounds, as you set the targets, oxygen target for these babies, you look at the monitor and how often do we see this target set at between 88 to 100%. It's so useful. And we have done some random audits on these limits and found that these limits were not kept at the appropriate number. So it's again something to look at. And when babies do desaturate, we often increase the oxygen concentration, and then it's important to bring it down as soon as the desaturation improves. And some of the machines, for example, if there is a desaturation, there are some buttons for oxygen flush where it gives a flush of oxygen at a set percentage above what the baby is getting. It's so important. I think it's in Fabian. I think it's available. This facility is available. And it's important to look at how much percentage. It's important to set how much percentage of oxygen we need to give if we have to press that button. So it's about attention to detail if we have to limit the amount of oxygen we are giving. I just want to highlight on another important one, which is nutrition and breastfeeding. Postnatal growth is a major risk factor for the ROP, especially postnatal weight gain in the first 6 weeks. And there are various screening tools which do use weight gain to predict the ROP. As you can see, the same review that I was doing, as you can see, the babies who did not do well with ROP, who did not do well with the weight gain, they were the ones who ended up having ROP. And you know, breast milk, it's such a repetition. Breast milk is the best milk, and it is so important that we give the breast milk for these babies. As you can see, the evidence, the systematic reviews have clearly shown that any amount of breast milk, human milk, is strongly associated with protection from all ROP and even severe ROP as well. Blood transfusion, I'm not going to go into the details because Deepu has already mentioned so beautifully. But again, just to highlight that blood transfusion is an independent risk factor, and every effort should be made to limit the blood transfusion. Pharmacological intervention that can be used to prevent ROP. Caffeine, the CAP trial, which came out many years ago, clearly showed that the caffeine treated infants had significantly less ROP. Vitamin A has been found to be useful, especially when given IM 3 times a week. But think of giving intramuscular injection of vitamin A for a 24-weeker, which has got hardly any muscle mass. It's quite hard. So there are recent studies which are looking at whether we can give daily supplemental vitamin A, and some early studies do show some benefits in reducing the ROP. Vitamin E hasn't been found to be of much use at all. Because IGF is linked to poor growth, because IGF deficiency has been linked to poor growth, which again is linked to ROP. So people are looking at whether IGF supplementation can be used, but the early studies haven't been very promising. Postnatal steroids have been looked at, and it's not been that exciting. A lot of other things are being tried, such as fish oil, out of which omega-3 fatty acids, early studies appears to be promising. Restol, inositol, COX inhibitors, and propranolol, they're all showing mixed results, and there are some ongoing trials. That's my presentation. Thank you.
Thank you, Shiva. We'll have questions in the end.